Welcome. Welcome all. I look forward to today's webinar on from the Ontario Health Teams from the Health System Performance Network. And today we have an excellent topic available that is advancing learning health system and using data and analytics for population insights. So that's going to be the place where we go to today. Please, thank you for joining us. Open the chat. And once you open the chat, I will ask if you could type into the chat who you are and where you might be joining us from. And I'm going to try and get over there so I can welcome people. Oh. Yeah, I can't seem to quite get to the chat for some reason today. Oh, there it is. Here we are. Joanne from Ottawa Inner City. And I see Gwen from Upper Grand Family Health Team and Guelph Wellington. So Sarah Good from Great River, welcome. Zoe from Waypoint. Deepak BI from Ontario Central Region, welcome. Let us know where you're joining us from. And even if you're not from an Ontario Health Team, if you're from Ontario Health or the Ministry or somewhere else. Leroy from the OHA, thank you very much. Let us know where you're joining us from. Lovely, fast and furious, everybody coming in. Barry Isaacs from Toronto. And Sandra, the Ontario Physician Reporting Center. Welcome, Sandra, to today's event. Welcome, Wendy. Nice to see you back again. And we're going to see some of the IDS today highlighted. So thanks, everybody. Please keep your introductions coming in. We're very much looking forward to one of our first whistle stops on the Ontario Health Teams tour of the learning health system. First, I would like to acknowledge I'm speaking to you from the University of Toronto today, and I'd like to acknowledge that land for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, the Mississaugas of the Credit, and today still home to many Indigenous peoples from across Turtle Island. And I'm definitely ever grateful that to have the opportunity to work here at the University of Toronto on this land. And many of you are joining us from all different lands, some of them treaties, some of them not. This is Treaty 13 here. And I welcome you to also acknowledge your own, the history of your location. Today, this is a depth into the inner workings of this learning health system. So last month, we had the great privilege of John Lavis, Rob Reed, and Maureen Smith leading us through what these gears were. And then also we had Kelly Smith from the East Toronto Health Partners talk about their approach to activating this and living it. So we're going to spend some time on this learning health system this year because we think it's a very important and opportunity way for OHTs and anybody really, but our focus is on OHTs to be able to use this to drive improvement and drive change. So really it's about making change happen. So the first stop in this gears, the inner workings, is on analytics and population insights. And so today we're going to talk about what does that mean? So using comprehensive data and in some cases more advanced, in some cases simpler analytic approaches on the populations served to understand the health services needs, gaps, inequities, preferences, aspirations, all of these things. How do you use data to understand the people that you're trying to serve and where there might be some opportunities for improvement, where the system gaps are, what are inequities? These are some of the questions you can be asking. And in terms of the kinds of people that might be doing this, well, everybody, but it includes business intelligence, it can include data decision analytics, program planning, patient family advisory councils. Everybody should become involved in doing this kind of work. We have a question about that a little later on today. I'm really, really excited to look into this aspect of the gears. This is where I spend a fair bit of my time in the Health System Performance Network as well. Okay, so just before we dive in, I'm just going to have people join up into a poll here and let us know if you have joined for an HSPN webinar previously. So I will ask, great, that poll is up now. People are answering in. Thanks, Tricia, for loading that up. And people are getting to be quite quick about this. And last month we had a larger number than usual. We're back, and so this time, let's see how we come out. We are pretty well there. Great. And Tricia, if you could share that poll back out, it would be lovely. For everybody can see now that 23% of people are here for the first time and 77% are returning. So we still have new people joining us each month. And I think that's amazing that we still have new outreach and hitting on new topics that people are finding useful. So thanks for joining us into there. We don't go away from that polling. We have another one right away. We're going to go on to the next one. And this is just to understand how people have already used data and what the sources of your data have been. So I will ask, and hopefully this is set up for check all that apply. And if it's not, then check the one that's most important. We'll see how things come. Great, people are entering their votes. And I say it looks like it's set up properly to have people being able to enter multiple votes. So I appreciate, Tricia, you're setting that up on the end there. And we have about 2/3 of people. And I see some others, also Statistics Canada data I see in the chat. Thank you very much. Other sources of data, please do let us know in the chat. I look forward to hearing about those other potential sources of data. This is not an exhaustive list, but certainly some of the ones that we'll be touching on today and more of them. And if we can probably share this poll back out now, most people have responded, and you might have to scroll down to see all the options here. But I also see that the most popular ones are around the Ontario Health Dashboard, the Ministry of Health data reports, and surveys on patient population or provider. I'm really, really happy to hear and to see that that those patient surveys are another source of data, and people are using quite a wide range of data. In fact, I think, except for the other, at least 40% of the respondents here are using all of these. They're kind of into all of the areas. So other partnerships with data, StatsCan, direct from community partners, Christine Olson from Mississauga, stats, census data, community partners data. Excellent to see these additional sources of data that people have been using. So we're very interested in understanding, and I think that's really important about this learning health system, is that you use all of the different sort of data sources you can think to try and get a bit of a scan and a deeper understanding of the work. So super, thanks very much. I'm going to host today a little bit, and I will talk a tiny bit about HSPN data, but for the most part, we have really excellent people driving this work across Ontario health teams in the province. And we're going to hear a couple of different parts of what they're doing. So Matthew Meyer, he's the Senior Director of Population Health Management, London Health Sciences, and the Population Health Lead for the Middlesex London Ontario Health Team. I know Matt through his role as a assistant professor at the Department of Epidemiology and Biostats, and he also holds adjunct positions in a number of other universities and departments, including at Western and Ottawa. Matt's had a long interest in pop health management, health economics, which is how we've run into each other. He's been advisor to the Ministry of Health, Ontario Health, Health Quality Ontario, and then the Southwestern Ontario Stroke Network many years back. Matt's been busy in this area for a while. Sarah Shirkani, Dr. Sarah Shirkani, is an evaluation equity scientist at Michael Garron and working in the East Toronto Health Partners, OHT. She's also an assistant professor here at IHPME, and she teaches in our program. She has been a CIHR Impact Fellow at East Toronto, and her PhD is in Health Services Research, and she has an MA in Economics prior to that. She also has a very extensive experience and research program involved with patients and carers and she has a certificate from the University of Calgary Patient Community Engagement and Research, or the PACER program, for those who know. We have also Sarah Grace Bebenek, who's the project manager at South Georgian Bay Ontario Health Team, and she has really been driving their model of care, driving improvements in healthcare that better connects patients and providers to improve those patient outcomes. And she brings her experience in quality improvement, project management, and patient advocacy, and you're going to see that come to light here. She has had much experience in supporting nonprofits and other groups in the South Georgian Bay area, and she has her honors BA in health sciences from Queen's, as well as a master's in global health and health management from McMaster. Finally, Emmy Perkins, the Director of Transformation, literally transformation in the Guelph Wellington Ontario Health Team. You can see some really innovative approaches to data from Emmy, and she's past chair of the Hamilton area chapter of the Canadian College of Health Service Executives. She's an active physiotherapist and has leadership experience in strategic and system planning of community, regional, and provincial programs. Her master's in health admin from University of Toronto, and Bachelor in Science from Physio from Western, and Bachelor of Science from York in kinesiology as well. So people with both applied clinical and patient experience throughout the system, and they are going to talk about some different elements of using data today. So we are going to first start our tour with in-depth OHT examples, understanding the population needs, Middlesex, London, then going deeper into the neighborhoods in East Toronto, using patient experience data in South Georgian Bay, and then going deep with linked data in Guelph, Wellington. So without further ado, I am happy to introduce Dr. Matt Meyer. Matt, you just let me know how to drive these little slides, and I'll keep it moving for you.
Thanks, Walter. Can you hear me okay?
Perfectly.
Awesome. So I'm really excited to be here. I absolutely love the learning health system framework, because I think it really perfectly encapsulates what we've been talking about from the beginning in Middlesex, London, and I know has been happening within a lot of other Ontario health teams. So what I thought I would do today is take the opportunity to just really walk us through the journey. So take us back to sort of step one. And that journey is certainly far from complete, but to kind of give you a sense for what we've been thinking about, and again, how much I think it aligns with what we've seen in this framework. So if you don't mind flipping on to the next slide, please. In the very brief time I have today, this is what I thought we would do. First, orient everyone to Middlesex, London and our philosophy, but then really just go back to the beginning and give an illustration of how we've used population health data from the beginning. Illustrate some of the key insights we've taken from that information. But then I think just as importantly, and one of the things I was really happy to see within the framework that's been proposed, is that when we talk about data, it's not just numbers, it's qualitative information as well. One of the terms that we've heard a lot in our OHT and seems to be popping up frequently is that we are data rich and information poor. And we've certainly acknowledged from the beginning that although we have wonderful data holdings to draw on, the context that comes from qualitative information and conversations is really important subset of that. So we don't want to lose sight of that. So in whirlwind fashion, if we could flip on to the next slide, please. This is our purpose statement that we've created in Middlesex, London. The reason why I wanted to start here is that we try to ground all of the work we're doing within this purpose statement of improving our healthcare experience together, where people are heard, care is connected, and whole health is possible for everyone. And you'll see this was developed in a co-design process, with patients, caregivers, providers, executives from across the system. And what you'll see in the words under some of the terminology there are elements of the quintuple aim, elements of integrated care, certainly elements of population health management. So we've been trying very actively from the beginning to be thinking about how we incorporate and embed those concepts in everything that we do. So if we can click to the next slide, I'm going to go through these fairly quickly, and part of why the formatting has changed is these are the actual slides that we used in 2019 when we were walking our then Western OHT Coordinating Council through what data we had available to inform the planning and thinking around Ontario health teams. So as Walter mentioned, in the early days, we dove very heavily into the Ministry of Health data that was provided to us. And so We were, really fortunate, again, speaking to the fact that we have wonderful data holdings. We got some data. We were able to present on the fact that we had 514,024 people that we were to support. We had some breakdown that helped us understand demographics from an age perspective, where they lived, how many were urban versus rural, some information about language, certainly visible minorities. So I'm not going to go through all the numbers in detail, but you can see we were fortunate to be able to share that information early on. If we click to the next slide, we also acknowledged early that we needed to supplement that information. One really key piece that has come out consistently is that we don't have fantastic information on our Indigenous populations. We were very fortunate in our area that we had just had our SOHAC, our regional AHAC, had just completed a survey of local Indigenous communities. And so we were able to draw on some of that and share that information with our coordinating council early on to acknowledge the importance of this information. If we can click to the next slide, what we also tried to do is dive a little bit more deeply into what we thought we could move on in the early days. So what were we starting to see in terms of trends and or opportunities? So very early on, we did identify that COPD and heart failure were fairly significant conditions, challenges being faced by our population, and able to work with our partners to start thinking about, how many bed days were being occupied. ALC is information that we consistently look at. So again, you can start to see across the continuum, we were trying to draw on what resources we had to paint the picture of how our system was functioning. And really, to be honest, one of the benefits of OHTs is that we had members of our inpatient rehab community, our long-term care community, our community support services at the table. So some of this journey early days was just orienting people to the kinds of data that we have across the system that they would not necessarily have seen. If we can click to the next slide, please. We also really wanted to make sure that we were incorporating the cost data. So this, again, was part of the package that we would have received as one of those early Ontario health teams, and I think others have received as well. And so we wanted to start looking through this information to start to share with people which were the groups that were driving the highest cost. And that's a very common population health management approach. And we were, again, really happy to see some of this included in some of those early packages. And it's something that we have to continue to keep our eyes on. But you'll see on the right-hand side, one of the things that really jumped out at us is that when you look at the HPGs that were driving our cost, 8 out of the 10 were with significant comorbidities. And of course, that didn't come as a surprise to anybody, but it was great to have the data to validate what people were saying at the table. So we click to the next slide. We also, went and had the fortune, as many others have, partnering with others and looking at what other data systems do we have access to. So as early as 2019, we were already partnering strongly with IDS, and so we were able to access some of that information through our London Health Sciences data support or decision support department. So they were able to pull some of this together again to give us more of a local context around, how many patients are we seeing? What are those conservable bed days? Where are the opportunities and where do they lie? And to illustrate what information we had access to. I will say, one of the things we found in that early exercise, though, was when we went across some of these different partners and started looking at what data they had access to, something that consistently came up was that the data pulls would be inconsistent. So the numbers were inconsistent. And data scientists would know why that happens. But it's really difficult to communicate to your partners in the system why we can't get the number to be the same across different data holdings, data sources. And so it became a really important source of conversation as we were thinking about how we're going to go forward and using data to inform our thinking. So we can click to the next slide, please. So here are the key lessons I would say when we're really kind of reflecting and thinking back to those early days. So one is, we said over and over and over and over again, 514,024, to the point where it became almost a joke within our OHT. And as we know, our attributed populations have shifted. So as that number has shifted, we've said other numbers as well. But we did that intentionally because right from the beginning, we wanted everyone to understand that if we're going to drive population health management, we need to acknowledge that those 514,024 people are people. And we need to start to get to the point where we're not just creating aggregate reports. We're starting to understand who they are at an individual level, what they need, and then designing the system to proactively connect with them. It's been a really important message from the beginning. And I would say in the early days, it seemed like we'd never get there. And then I think you're going to hear some presentations today that are going to show how we're actually starting to understand how we're going to do that. So that to me is really exciting. The other piece that really I reflected on having a chance to look at this was when we were looking through some of those data holdings, we had things like COPD as an example. The number that was given to us in that ministry data was 6,389 people. But when we looked at population-based prevalence estimates, those would suggest that within our attributed population, we should actually see more like 30,000 people. And the same is true for congestive heart failure. We really are, the data was suggesting or reporting about half of what we would expect to see from a population-based estimate. And it was a really important conversation, both at the coordinating council, but as we went out and started to reach out to partners, that information allowed us to start talking with people about who are we missing in these data holdings. And I'll say one of the most powerful conversations we had early days was when we went and met with some partners from our heart failure clinic, who are by far the local experts in management of heart failure and have been, actively involved in driving best practice recommendations, just a fantastic team. But when we met with them and talked to them about what they do on a day-to-day basis, we said, how many patients are you supporting? And they said, well, about 500 at a time. It was that 10,000 number that allowed us to say, so who's supporting the other 9,500? And I think it was a bit of a turning point. Those kinds of conversations were turning points to getting people to stop just thinking about existing programs and start thinking population. It was a huge piece for us. And we continue to have those conversations. And I'll say one of the things that's really exciting in some of the more recent data holdings that we're getting access to is we're starting to see some of those prevalence estimates come out. So we're getting a more accurate picture of our actual attributed population. The last point I wanted to make is there's also, as we've been exploring this, one of the key things is that we've been starting to be more aware of the data that we don't have access to. And a great example of that is we've consistently talked about the people who are unattached to primary care within our OHT, and we have an estimate of about 65,000. And the comment that we've been making consistently is it's unfortunate that that's just an estimate. We need to get to the point where we know who those people are by name so we can proactively connect with them and support them. So again, speaking to opportunities that we're now as OHTs starting to hear whispers of, maybe we will actually be able to get the names of some of those people, be able to work within those data holdings. So some of the key lessons as I reflected on our early numbers. So if we can click onto the next slide. So in kind of the last couple of minutes here, that's the way that we sort of looked at data early and how we've been on that same journey of really using it to ask questions within our OHT. But as I mentioned, what's been really important is we've been acknowledging that we need to supplement those numbers with other pieces of information. So we've done that in a couple of ways. If we can click on to the next slide, even in the early days, we acknowledge that we cannot pick a priority population strictly based on data. So the exercise that we undertook is we actually went out to our partners and said, you tell us what you think are the most burning priority populations that we should be focusing on. And we grounded that in concepts of change management, like which ones are we really able to support? Can we do something about, but which ones are also the most pressing challenges that you're feeling on the ground? If we click on to the next slide, that just gives you a sense for the process. But what was really interesting in that was through that, we had 7 population suggestions that came forward. One was very distinct. It was parents of infants that were supporting them in the early phases of life. We supported that group to go and actually speak with another OHT that was developing around pediatrics. But the other 6 populations that were recommended were a variation of COPD, CHF, people needing support, transitioning across care, people at risk of institutionalization. And when we got all of those 6 groups to come together into a room, they actually acknowledged that they really were talking about the same people. It was a really powerful exercise. So if we can click on to the next slide, please. The process was we got people into the room, and we had experts come with them into the room to kind of help facilitate those conversations. But what you see at the bottom is the recommendation for our priority population. And if we click to the next slide, this went to our coordinating council. We recommended through this process that our year one priority population should be older adults with chronic conditions in need of system level care coordination and navigation. So it really was only that we were focused on subpopulations of high-risk patients with COPD or CHF and older adults at risk of institutionalization. But this came out of that agreement that we're all kind of talking about the same group of people. It's interesting over time how this has slowly shifted to our OHT is focused on COPD and CHF. But I would say within our internal conversations, we haven't lost track of the other pieces. So I know I'm starting to get to the point at end of time. If we can just click quickly through these, and these will all be available to people, but we very actively in the beginning wanted to make sure that we were incorporating the voices of patients, clients, and care partners. So we formed a patient-client care partner council very early. The co-chair of that council is our co-chair of our coordinating council, and we make sure that we're thoroughly using that group at every step. On the next slide, what we did with that group is we wanted to make sure that we were thinking about a matrix so that when we went out and did experience-based co-design with groups to try to understand what we should be doing, that we were very intentionally making sure, you can see on the left-hand side, making sure that we were proactively reaching out to different sectors of our population and getting good representation from each of those sectors. And this is an ongoing process that we continue to kind of review. That our patient-client care partner council continues to kind of think about this, and within our co-design, we continue to think about this. So on the next slide, this is really the important piece, is what came out of that experience-based co-design are these 9 areas of focus, 10 areas of focus. And we consistently come back to these over and over again as part of our decision-making process as we think about taking on projects. So it's not just about the data. We can start with the data, but we always come back to how are we addressing one of these issues within each project. And the way we do that on the next slide is through a decision-making tool. So we've established a tool that we're happy to share. I know we've shared with some OHTs and happy to share beyond. That as we consider a project, we ask people to reflect on how is this project supporting each element of the quintuple aim, our OHT in meeting our purpose. Is it aligned with our co-design themes, as an example? Does it support our priority population? Is it scalable? And then we've actually added in some other elements too. So we're really wanting to make sure that we're honoring what came out of that experience-based co-design, and this is the way that we do it. So on the last slide, this for me was just my last kind of points around, I think if there are takeaways that I could share with the group from this process, and it's ongoing, is that there really is a ton that we can learn from the numbers. But there's a lot that we can also learn from the absence of numbers. And we've seen a lot and had a lot of really rich conversations when we've talked about what information is missing and how would we address that. And then the last piece, of course, is that really making sure that we're embedding everything within the right context.
Great. Thanks so much, Matt. I think there was a lot of information provided in there. And so we're just going to leave it open for a few moments because I know we don't have you for the full time. I'm going to fully take a break here, but if there are any questions from participants in the audience, we've asked them to put them in the chat. There are a couple comments that came in. Well, one certainly from Mike Heinmarsh, like making the excellent point about building disease-specific models. And in fact, actually, you're very explicit about not building disease-specific models. And I think that's, I'd also reinforce that point, I think, is that starting with a disease-based population around which you can build the model is, a tractable and a reasonable approach, I think, but really to be certain that what we're building is not for those conditions. I know I was looking at some data from one of the OHTs, and we looked, for example, in a COPD population, and 75% had 5 or more chronic conditions. And 10% of their hospitalizations were for COPD. And I actually think that's probably quite consistent across the province. And so, if you got like a 50% improvement in that one thing, it's a 5% improvement in their overall utilization, which, so just um, even though you can start there, you need to have that open mind and know that you're going to be addressing those persons that are needs. And I really like that you had goal-oriented care as an example, like assessing the goals, that it's a really a foundational piece, because I think at some point in time, as I understand it, disease-based protocols become, not irrelevant, but impossible. So we need to keep the goals, and then choose from amongst those goals then how to apply some of the guideline-based care and practices. I'm not seeing any additional questions coming up. I mean, sometimes it takes a little while for people to warm up a little bit, but I think you also gave a very clear presentation of the work that you've done, and I commend you, because it's, I think, a model for how OHTs should really try to use whatever information and sources of data that they have. And I think that was a really great example of using some of the early data from the ministry, but then talking with providers, talking with, involving the patient advisory group that you have and built to do this work, and then also to take the time to explain the data. I think that's a fundamental piece. And some people just other comments just supporting the work that you've been doing here, I think, in the comments now floating in. If we do get other questions later, we'll float them up to you.
Thanks. I'm happy to stay on for a few minutes. I'll just turn my camera off if there are any. Happy to answer now, and then please send on any others that come my way.
Super, thanks. So just for people to know that they're Matt's still here to see and watch those chat responses. I'm going to drop in, because kind of like one of the secondary sources people would have had pushed out to you were some early analytics data from the Health System Performance Network, and we've advanced a little bit, but in its essence, pretty well the backbone of what we've always had are these kind of presentation of results, and then also some raw numbers that kind of sit in Excel spreadsheets behind the scenes. And we've been making these available to the OHTs since about 2001. And we did last year. So I'm just to highlight for some of the people who haven't been here before, or who were not part of the webinars where we showed these results. These are all available on our website, both for the province, and then each individual OHT's version of these are also available. We kind of, in the high level display, aside from all the Excel tables of data, display data in two ways. One is these spider diagrams as an example, and it really provides a relative rank of all of the OHTs in the province, from the people who have the most of a particular event. So the best in the province would be close to the center, and the worst would be furthest out. I'm not sure best and worst is always the right way to use it, but say, for example, the highest cost people, OHTs are going to be on the outside, and the lowest cost per patient per month will be on the inside. We've highlighted a couple of ones here: continuity of care, ED visits best managed elsewhere, and ACSC, ambulatory care sensitive hospitalizations, that have been highlighted by the Ontario health teams as being very important to them. And then with those, we can then go to the next level, which is to say, in which populations, as an example, in which populations do you have the highest rates, or what are they across some different subpopulations, to start taking it down a few levels. So here's one that we've been paying a lot of attention to, and that is by material deprivation. This is a provincial result, but OHTs have their own results available. And we see here that the rate of ambulatory care hospitalizations per 100,000 people is 521 per 100,000 people in the areas of the province that have the highest material deprivation, and only 176. That's about close to being 3 times higher in those areas of the province where we have a lot of deprivation. So this says a couple of things. One, targeting resources. Two, there are probably other things going on than just healthcare, because I don't think our healthcare resources are that unequally distributed. So starting to understand that there may be other things just besides the medical care. And ambulatory care sensitive hospitalizations, if people are less familiar, are for things like COPD, CHF, diabetes, seizure disorders, and there's a few others that are in these kind of chronic conditions that we look at. Another one here, rates of emergency department visits, best managed elsewhere. And one thing I should say about these graphs is that the bars sometimes represent numbers of people and sometimes the rate per thousand people. So here for ED visits best managed elsewhere, this is per 1,000 person years by exposure. And we see here again a gradient. It doesn't get worse between the fourth and fifth quintiles here. In fact, it's about the stable, slightly better, but I'd consider that to be stable. But it is twice as high in those areas of greater deprivation as opposed to the areas with the least material deprivation or the wealthiest. So again, we see a socioeconomic gradient. And then we're also looking at these through a few other models. The intention here being narrowing in from that number of, Matt said, with 5,000 people hospitalized or 35,000, 65,000 people with the chronic conditions, to get into a more narrow group to understand where to make some differences. So here we're going to look at ED visits. Here it's by primary care model. And these results don't look the same. Very often family health teams, so for example, in diabetes management, family health teams have much better management. But here, when we're looking at ED visits, family health teams across the entire province generally have the highest rates of ED visits best managed elsewhere, whereas the other primary care models have lower ones. So if you're looking for volumes on avoiding ED visits, might want to inquire in and find out if there's work that can be done with the family health teams. The second highest proportion here are those people who do not have physicians or are not rostered to their physicians. They may have some access, but not rostered. So again, this takes it down one more level. I've got a couple other examples here, just three, and then we're going to tie off. This is by the CHI population grouping methodology. And we looked here at ALC days, which is another area of priority from some of the population groups. And so you can see here that the highest number of days, it has a number of days, is in this, people with major chronic conditions. They actually accumulate a lot of the ALC days, and the rate is also fairly high. The rate is even higher amongst those people who have major mental health conditions, though, as a proportion of that patient population, not as a proportion of all days, but a proportion of that patient population. So you can see here where they're being accumulated, for example, and relatively low, for example, almost non-existent in obstetrics, as one would hope. Other cancers being fairly low. And so you can start to see here where they are accumulating from. This is something fairly similar, but brought about using the BC Health System Matrix, which is another way that we look at it. One of the things this does do is, while the CHI data are more based upon hospital data and some physician billings, here we can know more about end-of-life care because we're tapping into some other data sources, such as the home care database, to know whether people are receiving palliative home care services. And so we actually see that there are more ALC days coming out of those palliative end-of-life patients than was apparent in the CHI. So two slightly different views, and the groupings here are a little bit different in terms of what you can see. The last two I'm just going to come to are around cancer screening. So here's one where we're looking at cancer screening by material deprivation. And here we'd like to see high numbers. And here we see that actually the people with the least deprived are the most likely to be up to date on their cervical cancer screening. And those people in the lower areas of socioeconomic status or higher deprivation, they have much lower rates of screening. And when we look here now at breast cancer screening, we have slightly different numbers, but again, here family health teams have the highest rates of screening. So again, using those resources, and people who are unattached or just in regular fee-for-service. Fee-for-service is much higher, it's a smaller group of people there, but unattached, only 46%. People who don't have a rostered physician are up to date with the breast cancer screening. So when you think about the interventions to address these needs, this can be helpful. And so hopefully people are using these data in those regards. We have a pretty amazing team that helped to support this work, and I just want to thank people on that. So again, that's sort of our HSPN. We are data providers in some regards. And so this is our way of helping you to look into it. And whatever you do, I think trying to move from that high to the next lower down is quite useful. Okay. So just before we move on to Dr. Shikani, I want to ask people with this other poll, how have you used or what types of information have you used to choose populations? So we're going to put up this poll. And I guess I want a bit of a sense of what types of data. The first one is more opinion, I think perceived issues. And then it's how are you interpreting? What's important to you? Is it the size of the population? Matt said they started with spending. Where were they spending a lot of the money? Quality of care, are you looking for where the gaps might be in quality of care? And or do you use patient experience? And if you have other examples that aren't in this list about how the type of information you're using to choose priority populations, let us know. And please pop that into the chat. We'll watch to see what there are a few other people choosing other sources, and I'll watch to see what they have to do. And we have EMR, popular appointment types. Thanks to Jim. And I think we can probably display up and share this back out. Wait times. Annabelle, I wonder if that's for procedures or I guess just across the board. People can be waiting for a lot of things in Canada, we know. Ontario being no exception. Okay, what do we have here? Well, population prevalence being slightly ahead of local knowledge and beliefs and quality of care. So those three all above 60% as popular data sources or sources of information. Patient experience being the next highest, also quite high with over 50% of people. And then cost burden, I think even getting good estimates of cost burden, we're just starting to look at this a little bit more commonly. And then others, which include those EMR, wait times, prevalence, actionable costs, patient priorities. That's interesting. I haven't seen the McDonald framework. I'll have to go look that up. Maybe I can cite somebody. ALC volumes, specialized needs as barriers. Yes. I think, from when I'm talking about using data, I'm usually looking for high burden, quality gap. There's evidence that we can actually do something to make a difference, that there are some evidence-based interventions, and we have providers that are willing to do those evidence-based pieces. I think then we can really move mountains. And I wonder if that's what that McDonald framework includes. And I appreciate they also include patient priorities in there. Great. So thanks for engaging on some of that and letting us know where you're using your data. Now we're going to kind of take it to another level down about understanding neighborhood data. This example coming from East Toronto, and Sarah Shikani is going to lead us through how, and I think, Sarah, you had a lead in a lot of this work. So I'll look forward to hearing how you went about this.
Thank you so much, Walter. So it's basically what I'm going to talk about is how we use the package that Walter and his team HSPN sent to us to bring people together and how to use the data and present the data in a way that is useful to set priorities and then co-design interventions. Next slide, please, Walter. Sorry, I have animations. I'm sorry, Walter, in advance. I totally forgot it, you guys driving this. So again, I think it was early in 2022 that HSPN sent a data package focused on CQIP, the collaborative quality improvement indicators that Walter just talked about, using population segmentation. So three CQIP indicators that they focused on, as Walter mentioned, were ALC days. There were emergency department presentation for mental health and addiction, and also 3 cancer screening rates. Next slide, please. As an OHT, as East Toronto Health Partners, or East Toronto OHT, we also received this package. So East Toronto Health Partners is a group of more than 100 community, primary care, home care, hospital, and social service organization in East Toronto, that they work together to create this integrated care system across East Toronto. We strive to partner with patients, family members, caregivers, and community members to improve the way East Toronto residents find and get care close to home. Next slide, please. So together we serve more than 350,000 people, and these residents live in 21 diverse neighborhoods, 5 of which are designated neighborhood improvement areas. So what we call priority neighborhoods, equity-seeking, equity-deserving communities. So a lot of work that we do is what we call a neighborhood model. We focus on neighborhoods, and we try to use data or and partner with local communities and local residents to drive change within neighborhoods. Next slide, please. We have been using, this is the earlier version of the learning health system model that Walter talked about. We've been trying to use this concept and this framework since 2018 that I became involved with East Toronto Health Partners in its initiations as a PhD student. Next slide, please. And then we were doing that by employing rapid cycles of evaluation. So we tested the idea, we had pilot programs, and we tested the idea. And center to this work is obviously data, qualitative data, quantitative data, internal data that we had, evaluation data that we had. And then, so when we received the package from Walter's team, we were all about, okay, if we're a learning health system, we need to use this data, and we need to use this data to drive change. Next slide, please. So it was all about, so we had the data, we need to understand it, and then act on it. Next slide. So at first, so when HSPN sent the data, I was a CIHR fellow. I was tasked with presenting the data package and the deck that Walter's team sent to us to different groups, those who were interested in data in East Toronto. So it was a bit scattered first because there were a lot of people that wanted to get their hands on this data and work with it. But slowly we managed to bring a small group of people internally, or experts internally and externally, together so that we can create these workshops, co-design sessions within which we present the data to the ETHB OHT as a whole. So we had evaluation specialists, we had QI specialists, we had patients and caregivers as partners within that small team. Next slide, please. We quickly noticed that we need to have a focus. So based on the data that we received, it was obvious to us that we needed to start from somewhere. So we needed to choose one indicator and to start this work with, and then replicate it throughout within our OHT, sorry. So based on the data that we received, it was obvious that we probably have a better chance to move things if we focused on cancer screening. Again, we had the data. We knew from Ontario and from Toronto, we knew that cancer screening rates went decreased during COVID. So that was our challenge. We received this sophisticated set of data, population segmentation data from Walter's group, and then we wanted to use it to co-design interventions. Next slide, please. So quickly we realized that again, that, okay, we cannot just jump into co-designing interventions, because we're trying to bring people from the community that like from different settings, from acute care, from home care, and also community members. So different people, different expertise, different background, different set of knowledge. So I felt that we need to do some level settings. So before starting co-designing anything for intervention, what we did was trying to do some level set, make sure that all of us speak the same language, we all have the same information, the same data, we understand what the issues are. And then after that, we can do the co-design. So we created 2 workshops, that small team that I talked about, including patients and caregivers. And in the first workshop, I was given the task of presenting the HSPN data. Next slide, please. And honestly, it was a daunting task. So it was still during COVID. The workshop was online, a whole day workshop. And we had these amazing, brilliant speakers, the really experts in their fields. They were amazing presenters, and then it was me. I had to present as dry data. So I created a slide deck, went to my team. They kind of didn't like it and like, okay, this is very dry, we might lose interest. I made changes based on their comment, but it was still not there. So I went through several iterations. I got definitely the help of our patients and caregivers to make sure what I'm saying it makes sense. Then at some point, I thought maybe I need to take this out of the healthcare system and look at other industries and see how they present data when they're dealing with diverse people in the room. And I have this hobby that we'll talk about momentarily that exposes me to a lot of people from all walks of life. Next slide, please. And that's pickleball. So there are some people that call pickleball geriatric tennis. They shall remain nameless. But I usually show these photos to them and say, look, these are the best male and female players in the world, and they're very young. In fact, the female player that you see here, she's only 16. But the reality is, in my community center, next slide, please. This is the scene. These are the people that I play with. I love them very much. There is a lot of wisdom going on. And a lot of them were high-level executive people from different industries. They have a lot of experience and knowledge, and they are nice people and they're willing to share. So one night after playing pickleball, we went out and I tried to pick their brain. They generally said the same thing that my team was saying, that I need to be brief and I need to be, everything needs to be simple. But one advice kind of stuck with me, which was, how about you turn everything on its head? In other words, how about you present the results and the key messages first? Next slide, please. If you could actually click some more, Walter. I have 4, 3, 4, perfect. So that led to some more research for me to remind me, what is data? So beyond the fact that it's information, it can be facts, it can be number, qualitative, quantitative. After some investigation, I realized that while data represents people's encounters with the care system, which means that by the time that we have access to data, conduct an analysis and discover trends, people have already lived through these experiences. So that gave me an idea. So I combined all the information that I received from my patient partners, from my community partners, and my pickleball group, and I thought, okay, I'm going to tell people that I have nothing new to present because they already lived it and they already know what I'm going to present. Next slide, please. So on the right side, I asked them why they think that we are focusing on cancer screening. They already knew the answer. I asked them who they think is most affected. Well, basically, they didn't go for cancer screening. The answer was like probably younger people, those who are healthier. That was correct, based on the data that we were seeing. And then I asked them, because one thing I forgot to tell you is that when HSPN provided us with data, we go back to them and ask for some neighborhood level data. They gave us based on postal codes that we provided to them, and I did some analysis myself and identified neighborhoods within our 21 neighborhoods the most affected. So I asked them, which neighborhoods do you think that they had the most decrease in cancer screening rate? And they obviously said priority neighborhoods. So I thought, wonderful. Now we can look at the data and graphs to basically support your experiences. So the key principles that we tried to follow was co-design, going back to the community members, ask them what we had in mind made sense to them. It was understanding the data, what data is, which is basically people's experiences. Tell a compelling story using data and facilitate participants to draw connections to their lived experience. And then the other piece was understanding the approach. So the approach that Walter and his team taken were very sophisticated. I had to understand it really well to be able to simplify it and then explain those complex concepts using simple visualization. Next slide, please. Thank you. So we had 2 workshops focused on basically level setting, giving people tools on how to even do a co-design co-design. So the quality improvement tools, evaluation tools, logic model, etc. Out of these 2 workshops, what people said to us, what came out was like, use the knowledge and existing knowledge and expertise in the community, mainly use the community health ambassadors to drive the work and drive change in the neighborhood when it comes to cancer screening. Community health ambassadors are the community members, residents of East Toronto, who speak the same language, share the same culture, and are willing to help out their the local residents. So then we had another workshop that we train community health ambassadors about cancer screening. If they're supposed to, for example, educate the locals about cancer screening, basically it was a train the trainer. They need to have more information about cancer screening. And then we, the different teams work on different interventions. One specific one that I want to highlight here was the Mars Innovation Challenge. That our team from Flemington basically won $50,000 to focus on cancer screening, increasing cancer screening, utilizing health community ambassadors, and then also using technology to find people who are probably behind and need to go for cancer screening. That was it. Thank you.
Thank you so much, Sarah. And what innovative opportunities that we're seeing people leverage here. Just absolutely amazing to even think about, like that last Mars challenge that you mentioned, like going out and using AI versions of technology to actually reach out to people. And I think the risk of inadvertently reaching out to the wrong person to see if they need to get cancer screening is probably relatively low. I think in some other things you might want to be a bit more careful, but in this kind of an example, right? Like there's really not too much harm, cost. And thanks for not mentioning my name. It was guessed. That was appreciated. We're going to go to a quick poll. I am conscious of time here, so usually we were going to break for a bit of a discussion here. So I think we are going to go to a poll, and I'm going to drop up 2 discussion topics and ask people to kind of join in a little bit in the chat to keep those discussion topics running. So here's a poll, and that is, I'm interested in knowing, and we're all interested in knowing, Sarah talked a lot about interpreting the data, and so did Matt, with different people. So we're interested in knowing a little bit of who you've engaged. So let us know when you've used data, who have you involved in, and has it been just, for example, and when I say OHT performance management or data team, just whoever your data team has to be or happens to be. Are they pretty well the only ones involved? Do you involve others in finding out what the data mean to them and asking them? And that, I think, can be challenging because it does require a lot of upfront training, discussion. You really have to plan things out very, very carefully. I know people may or may not recall, but back in the first year we provided data, which was like 2020, 21, we just dropped out some reports online, sent them around to individual teams with patient-specific data, and left it at that and said, I hope you have a good time with that. The next time we came around, we did provide a bit more interpretive and actually made sure that we had a chance to speak with the OHTs, and we're continuing that tradition now of doing a little bit of that translation and explaining and trying to provide the data in more usable formats, as opposed to just data in tables and make them easy to interpret, but also provide that additional data that you can use to format it yourselves as you need to. So we have, I think, fewer of the people, probably the people actually using the data or reporting in. So we have fewer people responding here, but maybe we could pop up the result of those people who have actually responded, which is about a third of our audience. And we see here that when we're looking at who's actually been involved, the performance team that's the main one, but it really seems that other groups, so working with the collaboration or leadership council, working with provider groups themselves, they're actually the ones need to act. So having them have a sense of the data. And then also a lot of people, 60% saying involving the patients and family through patient advisory groups. And some of the people, just over about 15%, also engaging with the community. So we can see that these are the main groups going in as well. So thanks for that. And here are the two questions, and we're going to go right on to have Sarah Grace from South Georgian Bay talk about their use of a different source of data, which is around patient experience. We're interested in knowing what your biggest barriers to using data for population insights are, and what are your biggest enablers. You don't have to do both. You can choose one. And I'll just ask, it would be easier for us to pick these out. If it's a barrier, put a little minus sign at the beginning of your text. And if it's an enabler, just put a little plus sign. So that's going to be our little code for whether you're talking about enablers or barriers here. And here we go. So Sarah Grace, some of you may have seen Sarah Grace present on their use along with their, they had one of their patient advisors on our webinar. I believe it was 2023, the first round. And now Sarah Grace came back to talk about the data in this context of how to use it in decision-making. Thank you so much for joining us today.
Great, thanks very much, Walter, and thanks for the opportunity to be here and speak with everyone this afternoon. I can go to the next slide, please. You can carry forward, perfect. So just a few objectives to guide our discussion this afternoon. I'll start just by giving a bit of an overview around our Ontario Health team and our structures, including highlighting how patients are embedded within all of our decision-making and operational teams. Then we'll move into just a further background to understand the patient experience survey process that we've undertaken with the support of HSPN. Reviewing a summary of these results, and then most importantly, how these results of our surveys have informed the work of our OHT Patient Family and Caregiver Advisory Council and the broader Ontario Health team as well for our South Georgian Bay population. Next slide, please. Perfect. So it was really great to see that many others on the call this afternoon also use patient and provider surveys and have engagement from their PFAC and their patient partners throughout their Ontario Health team structure. In this diagram that you can see here, this is a high-level overview or structure of how our Ontario Health team is set up. And I specifically wanted to point out our Patient, Family, and Caregiver Advisory Council that you can see on the top right corner there. Intentionally, there's the bidirectional arrow or information flow from the PFAC to the Collaboration Council, as they very much serve as an advisory table to the decision-making and to the operational decisions and structures of our Ontario Health Team Collaboration Council or executive table. Additionally, through our structures and relationships set up at the PFAC, we also have a patient or community representative on each of our action teams to really make sure that patient-centered voice is brought front and center, and that we truly do co-design our decisions through the workings of our OHT. Our Ontario Health team was part of the cohort 2 of OHTs across Ontario. We are relatively small. We have about a 65,000 patient population, and we primarily cover the areas of Collingwood, Wasaga Beach, Clearview, and a little bit in the Blue Mountains as well, bordering with the Grey Bruce Ontario Health team. You can go to the next slide, please. So this is just a bit of a background in terms of our experience delivering and distributing patient experience surveys to date. So as you can see there, the work really began in November of 2021, where our OHT PFAC met to evaluate what our options are for surveying our entire attributed population of our OHT. And through this process, we extensively reviewed available survey and prem and prom data collection opportunities, including the HSPN Patient Experience Survey, which was a relatively new tool at the time. So following this review, our PFAC recommended to our collaboration council to distribute it to our entire attributed population connected to our local primary care providers, which was ultimately approved. And that decision was made also in partnership with our Ontario Health Team Provider Care Network, which serves the same functions as many of the other primary care networks. So, sorry, not quite through that slide yet. Thank you. In South Georgian Bay, I wanted to mention too that we are fortunate that all of our primary care providers are on the same instance of the TELUS PS Suite EMR. So that does enable us to have quite a detailed and fulsome understanding and connection to our attributed population. So following the approval of the patient survey, we were able to run reports within our EMR system to identify these patients. We started off to get a set of baseline data set of everyone that had a primary care encounter in the last 2 years. And then we pulled those with an email and without an email. And then just carried forward with our distributing those surveys both electronically and by mail to make sure that it was an equitable distribution strategy. Next slide, please. Thank you. So this is a summary of our results from our 2022 survey responses, and apologies if this is a duplicate of information for some. But so through distributing the HSPN survey, both by secure email and mail, we were able to yield a statistically significant response rate, which has been used to inform the work of our PFAC and our OHT more broadly. And as I mentioned before, really serve to set that baseline in terms of our patient experience data across our attributed population. So in addition to the survey response rate, we also were really pleased to see that we saw an increase during this period of time where the survey was being completed. We also saw an increase in traffic to our OHT website, our social media pages, and we actually received many phone calls and emails from the community with excitement around the survey and the opportunity to provide input into our local health system, which was a really great kind of unexpected secondary outcome of that survey distribution. Next slide, please. So that brings us forward into our current work. So after receiving the results of the 2022 survey, the PFAC was then engaged to review the results and provide feedback to be incorporated into the next survey in terms of if there was anything we wanted to change or adjust. So our OHT worked with HSPN, and we're really grateful to them for the support that they provided and continue to provide to us to add a few customized questions to the survey to reflect localized services. And also our PFAC highlighted that it will be important to include both those that have access to primary care and those that don't, that we serve through some of our OHT projects, for example, our unattached patient clinic and our cancer screening services. So those patients were also included with their consent, of course, to be sent out the survey in our 2023 distribution. Next slide, please. So, oh, sorry, perfect. So you can see there were similar results that we were able to achieve in our 2023 survey. And the distribution of this survey, again, was done in collaboration with our PFAC and our OHT Provider Care Network, just so everyone was made aware that their patients were being surveyed. It was not specific to physicians. It's really just to understand what that broader health system perspective and access to services does look like. And then now we're really excited that by completing the survey for 2 years in a row, we'll now be able to analyze trends and opportunities that we weren't able to necessarily do by just having that one-time baseline data set last year. So we'll bring that forward now. We'll do a report analyzing the 2022 and 2023 data, which is underway, and we'll bring that forward to our action teams, our PFAC, and our collaboration council for their insights. So what does all of the survey data mean is the golden question. And we're really fortunate that we have been able to action quite a few projects and strategic deliverables as a result of the data that has come back through the survey. So some of the common themes that were addressed through the survey that also connect back with our OHT previous strategic plan and our upcoming strategic plan are, you can see there, so how to help to support patients who are, especially those that are most marginalized and vulnerable, and using the material deprivation index to help to inform some of that work as well. Assessing the patient experience for those with no family doctor and nurse practitioner or seemingly deemed unattached. And in our region, we also have quite a high number of patients that are those in our attributed population who have moved to our region, who may still have their physician elsewhere, like especially in the Toronto and GTA region. So it can be challenging for them to access services here while still trying to maintain that relationship with their physician elsewhere. The survey also pointed out opportunities for access to services and care, the patient and their caregiver involvement as a member of the care team, how patients perceive their use of digital tools to support their care, and understanding the demographics of our population as well, which we found really valuable, especially in some of those domains that may not typically be captured in more of a classic medical record type form. So as a result of the survey data and being able to assess our attributed population around these themes, there's been quite a lot of work that's been led through our PFAC, and I was hopeful to have our chair here today, but unfortunately are unable to attend. But some of the actions that I wanted to highlight that you can see there. So as a result of having better understanding around the growing percentage of people that are moving to our South Georgian Bay region who do not have access to primary care services, we were able to, based on that insight and having a better understanding around those patient needs, we were able to identify that there is actually a need for dedicated unattached services. And we're able to support that through a recent clinic that we've opened to support the unattached patient population. The PFAC has led the development of many different patient resources and advocacy supports, including a patient handbook, which is available across all of our primary care offices and our hospital outpatient services and emergency department as well. We primarily have that available in digital copies, but have print versions available as needed, certainly in French and English. So similarly, we're furthering our work around patient and caregiver advocacy, and that is, through the survey, we've also understood that that also means getting out into the community and having the opportunity to have that face-to-face and conversation-based community involvement as well. So now that we're kind of coming out of that COVID and virtual era, we're finding a lot of value in having that opportunity to get out into the community and engage with patients and families and caregivers directly. In collaboration with our PFAC, we've also developed a suite of tools to support digital use. So in our OHT, we have all of our primary care providers are able and are using online booking and messaging and many other digital tools to help to support them in their practice. So we want certainly to make sure that the patients are comfortable in using those tools and have the services available, such as translation and other services if they're not able to complete those options online. We have a primarily English-speaking first language population in our region, but that is quickly changing with the growth of our population. So we're ensuring that based on our survey data and consultation with community members, that our communications and our community engagement more broadly is available in multiple languages, making sure that it's AODA compliant at appropriate level of language, really to ensure that it's accessible to everyone in our community. And then also the data from the survey has been really, really valuable to help to inform our OHT decision-making and resource allocation by helping us to be able to see gaps and opportunities for program expansion and development, which we may not have seen before through specifically quantitative data and other sources, which are very valuable, but sometimes don't tell the whole story. So there's been a great complement from the quantitative data that we've had received in the past and this additional qualitative data. And the last thing that I'll mention that from an action, I know I'm just conscious of time, but as a result of the experience and the process of going through and delivering these surveys, we've worked with our PFAC to actually have a prem and prom survey developed for all of our OHT projects. So including like our cancer screening clinics, our unattached patient population work, are all incorporate elements of patient experience and provider experience measures to really use that as a foundational evaluation component to all of our work to ensure that it really is centered and adapting to the needs of our ever-changing community and population.
Well, thank you very much, Sarah Grace, for that comprehensive overview. And I'm going to watch for questions in the chat, but that I do want to make sure that we're actually going to slide right along to our last speaker. That was the discussion question I've already popped into the chat. I really appreciate that link of the information with the priority setting and the actions, right? Like that's, I think, one of the big places that that we're needing to advance. And it's not good enough just to provide data. It's not good enough just to explain the data. We actually have to start thinking about how will people use the data. And Emmy's done a lot of that engagement with the providers in particular. And Emmy's going to talk through one of the examples here of their going deep with linked data, leveraging IDS. Emmy, I'll turn it over to you.
Thanks, Walter, and good afternoon, everybody. Happy to go to the next slide. We'll go quickly through the slides, really telling the story about the journey in Guelph Wellington Ontario Health Team to use data to segment our population, and the approach that we've taken to do that, which really does align to the conversation that's been going on in the chat about building chronic disease prevention and management infrastructure across partners within our OHT. So specifically, a little bit about Guelph Wellington Ontario Health Team is that we do have a very high degree of primary care alignment. Specifically, approximately 95% of our physicians practice in team-based models. We have 5 family health teams and 1 community health center, to which the majority of physicians or primary care physicians in our community are affiliated. All of our primary care physicians use the same EMR, albeit they all use unique and separate instances of that EMR. We do have a relatively high primary care attachment rate, certainly not as high as it was pre-pandemic, but relative to some other parts in the province, certainly higher. And we do have many clinical champions for improving data. So next slide. It has been argued, and it's reasonably argued, that because of the primary care alignment in Guelph Wellington, that perhaps the data approach that I'm about to present may not be relevant for many parts of the province. I would propose that if we look at this map, whereby for each OHT, the segments of each OHT that is attached and in a fit versus attached in other models is approximately half of the OHTs have more than half of their population attached to some team-based model of care. So there is some applicability of this approach across other OHTs as well. Next slide. So really quickly, our model is one that sees Jane in the center there, her current experience, whereby she has some complexity related to her health and social needs. And by virtue of that, Jane described to us that she has many different care teams. And you can see them all there as indicated by the colored dots around her. She describes them as separate teams that sometimes share information with each other, but not always or not in a consistent way. And that she felt that she had a lot of people in her involved in her care, and that it was quite complex and difficult to keep track of. And despite having all of these people involved in her care, she still didn't know who to call when she was in her most vulnerable moments. And so Jane's ask to us was to please simplify her care team. She said, I would like one care team consisting of providers who know me, who know each other, and who I can contact when I am most in need. So it was with that request from Jane and others like her that we set out on our journey to develop the integrated patient care team model. Next slide. So this really is the IPCT model, which I'll explain in a minute. The other thing that drove us to this model is that physicians said, specifically primary care physicians said, please don't design a model of care whereby I have different ways of caring for different parts of the same person. Please, in Guelph Wellington, design a model of care that does, as sort of Mike was chatting about in the chat, really build that chronic disease prevention and management framework so that I can care for all parts of my complex patients and not have different ways of caring for different parts of them. So the IPCT model is one in which Jane will experience a single dedicated team of providers who are collectively dedicated and accountable to meet all of her care needs, and Jane is central to that team. In our IPCT model, it might mean integration of in-home care to start. It might mean the integration of different aspects of mental health and addictions care. But we really wanted to use data to say, what does each primary care team need in terms of additional resources that ought to be integrated first to meet the specific and unique needs of the population that is rostered to that team. We recognized that foundational to these teams are relationships, people getting to know each other, working alongside in a dedicated way, and that once they were a part of the single team, caring for Jane and the other patients rostered to the primary care team, they would need to be supported to have integrated documentation, integrated ways and streamlined ways of communicating with each other, and that would require harmonized privacy policies and practices. Next slide. So our model is one in which that considers condition-based pathways and also moves us up the continuum towards a full population health model, whereby we are considering complexity, so those patients with multiple conditions. And really, again, as was discussed in the chat, the chronic disease prevention and management infrastructure to be able to support patients in a streamlined and holistic way who have multiple conditions. Next slide. So this is our approach to segmentation, certainly wanting and working to understand the health of our population relative to the priority diagnoses. But more importantly, and the focus of this presentation is really understanding and segmenting our population based on the population health triangle at the primary care physician level. We are using the CIHI Pop Health Grouper to do that. And specifically, as I said, segmenting each physician's population so that we can say to those physicians, these are the patients on your roster who are in this high user and medically complex category. And we are going to provide those patients with a more intensive model of care. So it is really about identifying those who are more complex and providing them. So the so what for the physicians involved, because they do have to agree to contribute their data to IDS. The so what is that we will help you identify those who are most complex and provide those patients with a more intensive model of care. Next slide. Sorry, that animation just shows that we are overlaying the provincial priority populations and other diagnosis groups to ensure that best practices are being provided to those patients. The problem for us is that our primary care data wasn't easily accessible, and so we did need to develop a process by which primary care data could be contributed and incorporated with other system level data to make this happen. And so we invested in IDS, which stands for Integrated Decision Support. Next slide. When we started, we had many partners contributing to IDS, but over the course of the almost 5 years, I guess 4.5 now that the Guelph Wellington OHT has been in business, we have made significant investments in supporting other partners to also contribute to IDS, including several of our primary care partners. Next slide. I'm not going to go through this slide other than to say IDS and the work for us is to demonstrate the benefits of IDS both at the clinical level. So as I said, if primary care physicians are going to agree to contribute their data to IDS, we have to and have been working to demonstrate that there is value to them in doing so, specifically our ability to identify those who are most complex and provide them with a more intensive model of care. There's organizational and system value in helping us segment and then advance our population health approach. Some considerations is that we do have variable HIC models. So when we are inviting and supporting different physicians to contribute their data to IDS, in some cases it's the primary care team, the FIT or the CHC that is the HIC. In other cases, the individual physicians are the HIC. And so we have to customize and support those agreements based on the HIC model. There are costs associated with both extracting the data from the primary care EMR and for the support of IDS, and obviously privacy is of paramount concern, and we are continually monitoring for PIPA compliance. Next slide. So this is the fun stuff. A few more slides left. What we have been able to do is take the data contributed to IDS by primary care physicians, and this is super tiny and you don't need to see the numbers. It is all to demonstrate that in the first column of that really tiny graph, we have broken down the population roster to a single family health team according to the population health triangle. So we know how many patients within that team are within each category. We've then been able to say by physician, the patients on each physician's roster that fall within those categories within that family health team. We can say to the physician, and these are the patients. And so we have been able to do a chart audit to validate from the physician and the other primary care clinician team perspective that that patient reasonably fits within that category. Next slide. Once we validated that the patient is in fact reasonably in that level of the pop health group, where we are then doing some validation, as I said, and then completing a patient journey map to say who else in our system is involved in this patient's care. So if you think back to Jane and all the people that were involved in providing care for her many disease diagnoses, we can see from the patient journey map the different organizations and partners within our OHT that Jane has interacted with. And then we can reach out to those organizations and say, hey, come for a conversation about the care that we are each respectively providing to Jane, and let's have a discussion about how we can streamline our efforts and provide Jane with that single care team that she has been seeking. Next slide. Through that conversation with our system partners, we are developing and sharing shared care plans. I won't go into how we're doing that because of time, but the last slide is just another, so you can go to the next slide. It's another example of how we're using information that is contributed to IDS to be able to identify and then support those patients who are likely to die in the next year. So we've used a tool called the hospital 1-year mortality ratio. IDS has implemented it in their system so that rather than each hospital or hospital partner having to implement it into their HIS system, IDS has done it once. And as an OHT, we are able to identify all of the patients who, according to this validated tool, are likely to die in the next year, down to the patient level and their respective primary care physician, and we can support conversations between the clinician and the patient to provide those patients with a palliative approach to care. That is the rapid version of our presentation.
Indeed, that was a rapid version. I mean, I could tell towards the end that you were having to cram a couple of those pieces in, but I'm glad that you made it through each one of those elements because I think they were super important and highly valuable to us today. Maybe Sarah, I'll invite you to come off, and Sarah Grace as well to come off just to have a last little thank you for our participants and our audience today. What a whirlwind of really amazing knowledge and uses from each of you. And I think seeing, from the original of where Matt started off as some very crude data on population counts by Chi-Hi grouper, and then coming around to a totally different use at the very front lines of the Chi-Hi grouper. But then really engaging, Sarah in East Toronto with the patients about, what do you think is important and how do we prioritize this? And that discussion back and forth with the data, and Sarah Grace also really engaging with patients, family caregivers in this work. I think it's really been illuminating for us to think about using data of all different sorts, right? So quantitative, health admin, survey, patient voices, provider input, and to gather all of this knowledge together, and then to think about how do we think about priorities. Thank you again for sharing today. We are going to continue our tour around the learning health system in the in the months to come. And I look forward. Next month, we're going to be talking about evidence and what are some of the sources of evidence that OHTs can tap into. So I'm sure many of you have heard of, for example, RISE is a place to go and look for information, but there's actually another door just past RISE called the McMaster Health Forum that has more information on evidence-based practices. And Ottawa Hospital Research Institute also has people. So we're going to bring some of those other research knowledge, evidence groups to bear next month. And maybe we'll put one less on the agenda than we did this month. I really appreciate Emmy, Sarah Grace, and Matt for joining us today, and to all of our participants. I know I saw some chats, people coming who had to leave at the 1 hour mark, coming back to see it more, but most people are still here, and I appreciate your sticking it through to the end. I know I have more questions for our respondents that we're not going to get to today, but I want to thank everybody. Have a lovely afternoon. What an amazing day. Thank you, everyone. Take good care.